All right, this is Clostridium difficile, Dentistry's Overlooked Threat. My name is Dr. KRoling. I will be your speaker for this course. I am a public health dentist here in Phoenix, Arizona. Prior to that, I was in private practice as well as public health practice. Prior to being a dentist, I was a registered dental assistant. And as my role in public health, I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. It's the third largest health department in the US. And I oversaw multiple oral health programs and provided mobile care, worked with 45 dental hygienists every day, and multiple dentists. So again, welcome all to our presentation. For those of you watching this course at a later date, other than March the 17th, please scroll below the video player, access your quiz and your handouts in the instructions section. And for those of you on here live today, please be sure that you have the course folder and the handouts by tapping on the red banner at the top of the screen or checking your email. So Clostridium difficile, Dentistry's Overlooked Threat. So with all of my background, professor and public health program and preceptor for the public health program at Arizona School of Dentistry and Oral Health, I never expected to have C. difficile survivor as a label. You know, I never saw that on my bingo card, never saw it coming. I want to thank Dr. Jen for supporting our program, and following my presentation, they're going to be sharing with you their own experience with C. difficile, how their family was touched by Clostridium difficile, and how it helped them to innovate a product, Dr. Jen's Nanohydroxyapatite toothpaste. So please stay on for a few minutes because you'll be offered free samples as well. So who wants to turn away free samples? In your course folder, again, there is the link to access the quiz. For those of you watching it later date, scroll below this video player to the instructions section. All right, there's our conflict of interest and financial disclosure for this evening. I'm going to be discussing the pathogenesis, the clinical features, and current trends in virulence and prevalence of C. difficile infection, identify populations at increased risk, describe ways that C. difficile bacteria can be transmitted, and apply key principles and develop a specific strategy for infection control and prevention of C. difficile infection within the dental practice, which includes administrative controls, environmental cleaning, and antimicrobial stewardship. If any time you have any questions, please type them in the chat area. We recommend that you use Chrome browser or an up-to-date Safari. There may be a few of you out here today that had a family member or someone that you know that's had C. difficile, and a happy St. Patrick's Day to all of you, by the way, or may not have survived the infection. And I always have a few of you that reach out either through this class or at a later point. So C. diff survivor, again, was not something that I would have saw coming my way. I became ill in January of 2022, and C. difficile we'll talk about in much more detail here shortly, but it's a bacteria that is found everywhere in the natural environment. It happens to be in greater numbers within healthcare practices. There's contamination that we have to be concerned about. So when we take an antibiotic or there's something that disrupts our immune system or challenges our immune system, as we'll see, it can allow this bacteria to invade our gastrointestinal tract and colonize within our large intestine, producing toxins and causing colitis. And that colitis can be moderate to severe. It can be life-threatening, and it can kill, in the US, 30,000 every year, 15% within the first 30 days, and 500,000 become infected every year in the US. So in January of 2022, I underwent a periodontal procedure I fractured number 3, by the way. I have not had it replaced yet. That's another story. And my hope was that I would be able to have an implant. So I was referred to a periodontist locally who had been practicing for 40 years, very conservatively trained. And he agreed that the tooth should go and that I should have a socket graft with PRF and an implant placed a few months after that. So I agreed and had the procedure done January 11th, 2022. He prescribed clindamycin. Now, he prescribed antibiotics for every one of his surgical cases. This was a simple extraction, by the way, no infection present. But of course, there has to be some grinding of the bone and so forth for socket graft. I get that. So he prescribed clindamycin 150 milligrams 3 times daily for 6 days duration, 1 day prior to the procedure and 5 days afterwards. And I took the medication. In fact, I told him I wasn't excited about taking an antibiotic. I had not taken an antibiotic in over 12 years. When I picked up the prescription from CVS Pharmacy, the pharmacist told me, hey, doc, he knew me. Listen, you know the boxed warning on clindamycin, but you don't fit the patient that we're concerned about. You're not an elderly person in a nursing home. You're not in a hospital. This isn't an IV and administration. These are capsules, so you're going to be fine. So I drove away thinking I was going to be fine. I had a periodontist telling me that he had great patient outcomes. This is a procedure he's always done. He's followed for 40 years. I put my trust in him. I put my trust in the pharmacist. I returned to his practice a couple of times for post-operative check. And on the 30-day post-operative check, he let me know that everything looked great. I was no longer on a soft food diet. I was yippee because I was getting pretty tired of soup. And he said, let's see you back here in 3 to 4 months to reevaluate you for an implant, but everything looks great. So again, I drove away thinking everything was great. And I was really happy to get that all behind me. 48 hours later, I developed acute gastrointestinal symptoms. I was bleeding, defecating blood, and I felt that it was something maybe colorectal cancer. Couldn't imagine what this could be. There was something in the back of my mind that asked myself, self to self, could this be C. difficile? And I got online, and to my shock and horror, I saw that you could develop C. difficile up to 90 days after you finished an antibiotic. And I was trained to believe at UCSF, and this was a while ago, that the patient would develop C. difficile symptoms while taking the antibiotic or shortly around that time. But this was an entire month after I had completed a 6-day course. I also was shocked to see that patients were dying from this and that the prevalence was increasing and that patients that took an antidiarrheal were at great risk for developing a condition that we'll talk about, toxic megacolon, where they died. And so I told myself, you need to get to a gastroenterologist right away and rule out all the bad stuff, and do not take an antidiarrheal until you have a definitive diagnosis. So the next day, those symptoms turned into bloody, watery diarrhea about every 20 to 30 minutes. And I was in a lot of pain, saw urgent care. I was misdiagnosed with irritable bowel syndrome, and I was prescribed an antidiarrheal. I asked them, do you think this could be this could be C. difficile? Because I was prescribed clindamycin by my dentist 30 days ago, and I am a dentist, and I'm concerned that this could be C. difficile. And the doctor said, oh no, you would know it if it was C. difficile. Well, obviously I didn't, and he didn't either. The next day I had a lull in my symptoms. So I thought, well, maybe this was IBS, right? But I did not take the antidiarrheal. And the following day, my symptoms, I had bloody, watery diarrhea about every 15 minutes. I was quickly becoming very dehydrated. I saw urgent care again. They assured me it was not C. difficile, it was IBS, And this time they wanted me to take Lamodal, which was prescription. And he said, if you don't take it, we're going to be right back where we are right now, because they put 2 bags of fluid in me. So I told myself, I'm just going to continue to be a bad patient until gastroenterology could get me in. There was a delay because of the pandemic. When I arrived at the gastroenterologist's office about 3 or 4 days later, and by the way, at urgent care, I had a temperature of 102. I was in sinus tachy. I was hypertensive, and they attributed it all to being dehydrated. So when I was seen by gastroenterology, I was telling the gastroenterologist my symptoms. He had a resident there from the University of Arizona. And finally, he threw his arms up in the air and said, Kirsten, what do you think this is? I said, Dr. Singh, I'm really worried it could be C. difficile. He said, it is C. difficile. He said, we have to get you to the lab right away and get you tested, and do not take the antidiarrheals because of toxic megacolon. He said, I need you to go straight to the lab. And I was in a diaper. I was completely incontinent in Uber cars, by the way, doing Lamaze breathing because I was so worried that I was going to have some sort of accident in the Uber car. So that's just to let you know how serious this is. So I get to the lab. The next day, I was called and informed I had C. difficile. And I'm going to show you what those laboratory results look like. They're right here. So my calprotectin, which is an inflammatory marker for colitis, should have been less than 49. I was at 753. I was very, very ill. And they prescribed oral vancomycin. And I was hoping that I would be cured after 10 days of oral vancomycin and life would be back to normal. However, it was not, because I had 3 recurrent infections after that. Very common for recurrent infections. The first one, you have a 30-day or 30% chance of it coming back. I was in the hospital 4 times, each time admitted through the emergency department, twice by ambulance. I lost 30 pounds within a few weeks because I was only able to ingest clear fluids. I was on colon rest every time. I weighed 92 pounds by the time I got to about 4 months after my first infection, and I was dying. And I am not exaggerating this. I had to get my affairs in order. That's why I'm teaching this course, because I want you all to understand how serious of an infection this is. At this point, I had an antibiotic-resistant infection, so I was not responding to any of the medications. One of the antibiotics was almost $6,000. It was out of pocket for me. I was assured that it was going to stop the recurrent infections. It did not. In fact, it came back even worse than the first 4 times. So at this point, I decided I was going to need to save my own life, and I got online and researched and found clinical trials where I could be entered into a clinical trial for a fecal transplant. And I was lucky enough to find one of the providers right here in Scottsdale, Arizona, right up the road from me, who was able to get me into endoscopy at Honor Health within 4 days, because he took one look at me and he said, we have to get you in right away. After the fecal microbiome transplant, and it's exactly what you think it is, it's a donor fecal material and it's placed by colonoscopy. After that procedure, which has a 95% cure rate, I felt completely cured, at least initially, meaning it felt like a fog was lifted. I didn't feel sick anymore. I didn't have diarrhea anymore. I had diarrhea for almost 6 months, right? But there was a recovery process. I had to stay away from people who might make me sick, give me COVID. I had a year of more social isolation. I had to prepare all my food at home. I couldn't use products that could disrupt an already disrupted gut microbiome. And because I had the fecal transplant, I had to be sure that I didn't enter anything that was a gut disruptor. All right. I want you to know that now I am lactose and gluten intolerant. I do have IBS, post-infectious IBS. It's very hard for me to eat. It's very hard for me to go out and eat anything. My life has been inextricably changed by this infection. It's a frightening, isolating disease. It kicks you to the ground. And just when you think you don't have any more strength and you're going to give up, it kicks you one more time just to remind you who's in charge. And I was not in charge. Recovery, again, is still in process. I'll be monitored for the rest of my life because of the clinical trial, because of the fecal transplant. There are things that they will constantly be monitoring for me. Rheumatoid arthritis is an effect of these FMTs long-term. So I was just tested for that and so forth. Epstein-Barr is another. And some of the cancers, colorectal cancer. So the total bill to my insurance, $86,000 for a simple extraction of number 3. And I want you to see my timeline here. And that's me on the right-hand side, weighing in at 92 pounds. This was one day after the fecal transplant, and I was eating real food for the first time. Not a lot, but eating something, and anything crunchy to me was really, really hopeful. So let's talk about transmission now, pathophysiology, prevalence, and risk factors. Before we start talking antibiotics, please hold on to that, Jean, okay? So when I trained at UCSF, I remember the lecture on Clostridium difficile was really how to pass the boards, right? UCSF is all about passing the national boards. And what I learned was that you give a patient an antibiotic. If they develop watery diarrhea or bloody watery diarrhea, they should be tested for C. difficile. The prognosis for patients that aren't elderly, for instance, is better. Oftentimes, if it's severe at that time, this was 30 years ago, the patient would be hospitalized and given an IV of oral vancomycin. Other than that, if it was a moderate case, they may get metronidazole. Well, metronidazole does not cut it anymore. This bug is a super bug now. So metronidazole really doesn't treat these cases. It's only used really in nursing homes where cost is a factor. And the death rate of older adults in nursing homes, C. diff, is tragic. So no more metronidazole, it just doesn't work. And now oral vancomycin is becoming another resistant antibiotic or resistant to this bacteria. So what is Clostridium difficile? It's a bacteria, it's an obligate anaerobe, it's not going to live in the presence of oxygen. It's a gram-positive rod. It's toxin producing and spore forming. It produces toxins A and B. I had toxin B. And it forms spores when it's in an environment where it would not normally survive. It's transmitted by the oral to fecal route. But most of the time, it's transmitted due to cross-contamination. And we do need to worry about cross-contamination in our dental practices, as we'll see shortly. The spores are found everywhere in the natural environment, the soil, the seawater, rivers, air, even the bottoms of your shoes. So be really careful not wearing your shoes in your house, and don't wear your work shoes home. You really should either wear shoe covers and leave your shoes at work and wear home shoes to your home. How can you protect yourself? Just simply washing your hands effectively and making sure that you disinfect your surfaces correctly. All right, there are 2 phases of the C. difficile infection here. The vegetative form, that is the form that is associated with the symptoms that produces toxin A and B leading to the colitis, and the spore form. The spore is the cocoon. So again, the bacteria may be in an aerobic condition, it cocoons up, and it can live to months, some even believe years, indefinitely It's very difficult to kill. So the vegetative form can live on moist surfaces for just up to 6 hours, but it's going to die, and it's susceptible to your stomach acids. It is susceptible to just washing your hands with antimicrobial soap and water, and it's also susceptible to alcohol-based hand sanitizer, all when they are used correctly. But the spores, again, can live on objects and counters and flooring and the bottom of your shoes for months to years. And they can continue to be shed by someone like me that has been infected. They are resistant to the gastric acids of your stomach, antibacterial soaps, and they're also resistant to alcohol-based hand sanitizers. And given the right conditions, they can rapidly change to the vegetative form. So how is C. difficile transmitted? Well, let's take a look at this graphic here. Some point we ingest a spore. This is called the oral to fecal route. The majority of time, we come into contact with contamination on our hands. Maybe we're eating something and we ingest the spore, right? So we ingest it, it passes through the esophagus, it gets to the stomach. The spore is not going to be affected by the gastric acids of the stomach. Hydrochloric acid will not do anything. It gets to the small intestine where it's met with bile acid exposure. The gallbladder will eject bile salts, and those spores will germinate to its vegetative form. And the vegetative cells will continue on to the large intestine. They'll rapidly divide. They'll get to the large intestine where they will colonize the large intestine, infecting the lining of the large intestine, producing the toxins A and B, or A or B, and causing what we used to call pseudomembranous colitis or colitis. And that is how it occurs. Now, the gut microbiome is what we're talking about here. It is our special defense system. It's part of the nonspecific immune system. And when we prescribe antibiotics, even a single dose, we can disrupt the gut microbiome. And by the way, it's not just clindamycin anymore. It's any antibiotic, any dose, any duration. So the community of bacteria and other microbes in the colon, we call the gut microbiome, protect us from pathogens to be able to fight off things like a Clostridium difficile infection. And colonization resistance is the reference term for this gut microbiome, becomes disrupted when antibiotics are introduced, allowing Clostridium difficile to proliferate, produce toxins, and cause the symptoms. Now, I was also trained to believe that if a patient developed a C. difficile infection, it was a result of the fact that they were carriers. They must have somewhere along the way became colonized, but they maybe didn't get ill, and we gave them an antibiotic, affected the gut. We called the gut flora at that time. That created a niche for these spores and the germination of such to take over and proliferate and produce those toxins. Almost like an opportunistic infection. But we know now that carriers only represent 0.4 to 15% of the general population, and that 15% would be someone like me. How do patients get C. difficile? They're given an antibiotic, and they're invited back into an environment that is contaminated with C. difficile spores. And healthcare practices are contaminated with C. diff spores. We're going to hear a video here shortly, including dental practices. All healthcare practices are at a greater level than non-healthcare practices. So carriers, we know, can be asymptomatic and spread germs to others who may develop a serious infection. However, we do know that many of these cases have to do with contamination. And we'll talk about that shortly here. So what are the symptoms? Watery diarrhea 3 times more a day, mild abdominal cramping and tenderness. Those are considered the mild symptoms. The moderate to severe symptoms, watery diarrhea or bloody watery diarrhea, 10 to 15 times a day, abdominal cramping and pain that can be quite severe, rapid heart rate, dehydration, fever, nausea, increased white blood cell count, kidney failure, blood or pus in the stool, sepsis can be a life-threatening complication, ileus or toxic megacolon. And by the way, sepsis does not align necessarily with severity of disease or severity of infection. So there are cases where one develops sepsis and may not have had a severe case of C. difficile. And that goes with other infections as well. But getting back to C. difficile here, ileus and toxic megacolon are considered the life-threatening complications. Ileus is a paralysis of the small bowel, and toxic megacolon occurs when a patient has been told to take an antidiarrheal and the colon loses motility. And remember, these bacteria are toxin producing, and they produce the toxins, a gas forms, the colon expands like a balloon, becoming thinner and thinner, perhaps perforating, or it can burst, it can explode. And that is a death sentence for the patient. So looking at this slide, on the left-hand side, you see a colon. This is pus, and this is blood. This is a C. diff spore next to that. And the radiolucency in this image here is somebody's colon. Huge. On the right-hand side, you see a colon here that is about 11 inches in diameter. On the next slide, you see a case of toxic megacolon, where the colon has been removed. And quite often, the patient does not survive this experience. And if they do survive, they are going to be defecating in a bag for the rest of their life. We'll be looking at a couple of those cases. So who's affected? Anyone, but the following populations are at greater risk. Anyone taking antibiotics, proton pump inhibitors, immunosuppressive drugs. So if you're taking the purple pill, omeprazole, and so forth, you could be at greater risk for C. difficile. Anyone admitted to a hospital, nursing home residents as well, over the age of 65. Female, we're not sure why. In fact, there's data to suggest that females given clindamycin have a 3 times greater risk than their male counterparts to developing C. difficile. The immunocompromised, cancer, HIV patients, anyone with a prior C. difficile infection. So I hope after today, you'll start asking your patients if they've had C. difficile in the past, if they've had diarrhea in the past associated with an antibiotic, because they may not remember the name, but they may remember the experience. Why do we need to know that? Because we cannot prescribe antibiotics to these patients until we get all healthcare providers involved. For instance, I would not be able to take an antibiotic, and your antibiotic is no better than anybody else's. And I've heard these stories where the dentist would say, look, I'm just going to give you a little amoxicillin and you should be okay. We can't tell the patient that, because they may have to be in a hospital or an infusion center with a monoclonal antibody called Zinplava and another antibiotic called DIFFICILE to help prevent severe illness from C. difficile. So there has to be a plan in place. Your antibiotic, unfortunately, is no better than anybody else's. It can cause a recurrence of C. difficile. There are nearly 500,000 initial cases every year, 30,000 associated deaths, 15% of those in the first 30 days of initial infection. You can bet I was counting down the calendar, folks. Recurrent C. diff infection has a 20 to 30%, at least with the first recurrence, and then 5 to 10% with multiple recurrences. By the time you get to a third recurrent infection, you have a 90% chance of that infection returning. And the hospital cost to treat C. difficile in the US annually, $5.9 billion. So let's all hope Elon Musk stays away from that, okay? That's humor. C. diff data here. All right, around 500,000 infections are caused by C. difficile every year. Up to 1/3 of those that are infected may get it again. And after the first recurrence, up to 6 in 10 are likely to get another C. difficile infection. And 8 in 10 with recurrent C. difficile were hospitalized in 12 months and at least 3 separate times. So in my case, I was hospitalized 4 times within 6 months. The prevalence and severity of C. difficile infection is increasing in outpatient settings. So hospitals are fined if a patient develops an infection because they're in that hospital, whether it's Clostridium difficile or MRSA or whatever, they can be fined. The insurance companies can refuse to pay the bill, so the bill is on the hospital. And the patient may turn around, or the patient's family may turn around and sue the hospital. So there's a financial motivator for these hospitals to get their act together and make sure their patients aren't going to get C. difficile while you're in their hospital. And I see Tara is on here. She works in the hospital. She's treated these patients and she knows what I'm talking about here. There are things in place when you are a C. diff patient. Patients that come to visit you, if they're allowed to, they have to gown up, put on PPE, make sure they apply effective hand hygiene, glove, the whole 9 yards before they can enter your room. And then the process starts when they leave, right? So the outpatient setting is now a concern, and dental practices are outpatient settings. And we call those community-associated infections. Anything outside of a hospital stay. And we see these cases increasing in outpatient settings. CDC has classified C. difficile as an urgent threat, one of the top 4 antimicrobial threats with the greatest number of deaths and the second greatest number of cases. And yet it is not required to be nationally notifiable. And you may see that in your quiz. Let's talk quickly about antibiotics here. Any questions? I see there are a few there. I'm going to play a quick video and then I will address your questions. There might be a few of you that cannot hear this video. The link is in your handout. If you don't have the handout, tap on that red banner at the top of the screen.
My name is Christina. I'm from Columbia, Missouri. C. diff for me started in 2012 from the overuse of antibiotics as a preventative measure for a root canal. Within a week, I knew that things were very, very wrong and was quickly put in the hospital and diagnosed with C. diff, which I had never heard of before. I was about to be married, so I wanted to be planning my wedding during that time, but instead, the next 7 months, I was in and out of the hospital 6 times. I missed 7 months of work, and I was growing gravely ill and dying. I barely made it out of the hospital in time to attend my own wedding, and my honeymoon was instead spent in the geriatric ward, too weak to even stand. All the antibiotic treatments failed me, so I resorted to the FMT, which is the fecal transplant, and that ended up saving my life. Fast forward about 3 years, I had a 2-year-old little girl named Pearl. I was 9 months pregnant with our son, and my daughter became violently ill. And I never gave her antibiotics, so it was my horror when she was hospitalized and diagnosed with a C. diff infection. And I watched her endure the pain, the fear, the sickness, the isolation, and for a 2-year-old, that's very scary. I realized that, the body is a lot stronger than I've been giving it credit, and it's been 5 years and I have not needed any antibiotics. I've been able to fight on my own.
Any theory about why her little girl may have become infected. She's not been on antibiotics. Exposure in the house, exactly. Spores from the mom, cross-contamination. So mom may still be shedding spores. And again, those spores last forever. I can tell you when I became infected to be enrolled in the clinical trial for the FMT, I had to completely have my home completely mitigated for C. difficile spores. And I was so weak because they gave you this like protocol. You had to scrub everything down and then use bleach or hypochlorous acid, which we'll talk about. And I couldn't do it. So I had to call a biohazard team to come in and mitigate for those spores so that I didn't reinfect myself or my family or my pets. All right, so in your course folder, there is a link to the EPA's List K for killing these spores. Anything with a label that is on EPA List K will kill the spores. The other thing that kills spores, of course, is your autoclave. So spores require high heat and pressure. That's why we use autoclaves, or disinfectant that is strong enough in concentration that will kill the spores. And there are some studies now that even bleach will not kill these spores. I'm going to play another quick video here to talk to you about that. And they're going to talk about how C. difficile is transmitted, and they're going to call out dental practices. So these are 6 experts. Dr. Paul Furestad, who you'll see on the top right, is a global expert, gastroenterologist, published hundreds of studies on C. difficile, recurrent C. difficile, mental health aspects of recurrent C. difficile, and others here, infectious diseases experts, and so forth.
So let's talk about community C. diff, if we could, for a moment. What are the risk factors in the community, and how do they differ in the community versus the hospital-based population here? Dale, you want to start us on that?
Yeah, that's a really good question, because there's 2 factors that we need to have in order to get C. diff. One is antibiotic use, and the other is exposure to the spores. So the spores are ubiquitous. They're out in the environment. They even contaminate at a very low level some foods, meats, root vegetables, lettuce, and those are probably how patients in the community get exposed. They, on the other hand, when the CDC has looked at community-associated C. diff, they found that about 80% of these patients have had an exposure to healthcare as an outpatient. So it's doctor's office, dental office, and chronic dialysis units, ambulatory surgery. And this is where you have 2 risks. One is that somebody's going to give you an antibiotic, and those are called doctors. And
we hope it's only doctors.
They put people at risk of C. diff. And the other exposure is that the healthcare environment is more contaminated with C. diff spores than is the environment outside of healthcare.
And I think it's worth noting, Paul is nodding his head. He does a lot of nodding. It's not just the people who are in the healthcare system. It's not just the people who got the antibiotics. They go home. They've got spores, and then their families are exposed. So it seems to me that that's part of the issue, isn't it?
And those spores can live for a significant period of time on many different surfaces, even when exposed to sunlight. And you'll see some data that says alcohol in certain products can kill the spores, but that it really has to be used properly, where where the liquid sits on a surface for a significant period of time to have its effects. So the fact that the spores can be taken home with you on your lab coat and in your house and on surfaces for 6 months or a year or longer certainly put people at risk.
I'll talk more about disinfectant here shortly. We had a question about ozone therapy. So ozone therapy has been studied, and its effects so far have not been able to kill these spores. And so you'll see that if you do a Google search. And they've used it also in the presence of UVC lighting and other applications. These spores are very, very difficult to kill. All right. ADA's evidence-based guidelines for antibiotic urgent pain and swelling. And you're going to see a link to a course that we're offering here on the 28th, actually live. It's also available on demand by Dr. Tom Pommier, who is the ADA's co-author of a few of these guidelines, prophylaxis for joint replacement and odontogenic infections. I'm showing you the link to the 2019 because over the weekend, we had this released prior to the ADA's release of this study, outpatient antibiotic prescribing by general dentists in the US from 2018 through 2022. And they wanted to study antibiotic prescribing changes by dentists after the ADA's 2019 dental infection and treatment guideline was released to see if it made any difference in the numbers. So they looked at the exponent database, which they extract antibiotic prescriptions from all pharmacies dispensed from 2018 through 2022. And general dentist prescriptions were compared with total outpatient oral antibiotics and summarized by patient and provider characteristics. Census denominators were used. They were going to calculate prescribing rates per 1,000 people. And what did they find? The results: dentists prescribed 24.65 million antibiotics in 2018, compared with 25.17 million in 22. So there was a slight increase, resulting in 75.5 prescriptions per 1,000 people for both years. From 2018 through 2022, dentists prescribed 9.8% through 12.1% of all outpatient antibiotics, and females, patients 65 and older, and patients in the Northeast received the most antibiotic prescriptions. Now, we just heard about the patients that seem to have greater risk factors, females and those over 65. So it's a little concerning. Was it the chicken or the egg here, right? Conclusion here: prescribing by general dentists remains stable from 2018 through 2022, despite guideline recommendations to limit antibiotic use for dental infections, and variation by patient and provider characteristics may represent unnecessary antibiotic use. So the practical implications here: antibiotic stewardship is needed, and we'll talk about that here shortly. So this is the course coming up March the 28th. Dr. Pommier is the past president of the Ohio Dental Association and the co-author of many of those guidelines that we just showed you. And this course is also available on demand. It's 4 hours. Take it and complete it on your own time. If you take any course this year, this is the course you want to take after you hear this discussion. All right, so dentists are estimated to prescribe 10% of antibiotics. And the antibiotics associated with greater risk are clindamycin, cephalosporins, and the fluoroquinolones. This was a study that found 81% of dental antibiotic prescribing wasn't needed because the patient did not have a heart condition, placing them at the highest risk of an adverse outcome from infective endocarditis. And amoxicillin was the number one antibiotic prescribed. Clindamycin was the second most frequently prescribed. But newsflash, the American Dental Association removed clindamycin from the prophylaxis guidelines back in 2019, I believe in 2021, for both infective endocarditis and joint replacement. Why? Because of the numbers of patients developing C. difficile and the numbers of dentists being sued because of that. So another study in Minnesota also saw that 30% or so of the prescribing not required. Now, it's a challenge because the specialist may want you to prescribe the antibiotic, and there are many of you that are under the notion that if you get a quote medical clearance from the specialist, that you can go ahead and write the prescription, or they may write the prescription, or you may have your hygienist or your front office dispensing that antibiotic from your practice based on quote this medical clearance. And this is a spoiler alert, but what Dr. Palmier is going to tell you, and he's an expert witness on these cases, that will not absolve you from liability. It will not absolve you from liability because it's your procedure. So if the prescribing falls outside of the AA's guidelines, it's putting you at risk for liability, and it's putting your patient and others at risk for illness. So the Minnesota Department of Health tracked community-associated C. diff infections, and they found during a 6-year period that researchers determined 15% of those with the infection had taken antibiotics prescribed for dental procedures. 1/3 of those medical charts included no mention of receiving dental procedure-related antibiotics. Why? Because the patient probably was not consented to be on the lookout for C. difficile or symptoms. So hopefully after today, your patient, you will let them know that Clostridium difficile can occur up to 90 days afterwards. And here are the symptoms. And if you develop these symptoms, I want you to call me. I'm the one providing the service to you or the procedure. You'll need to call me. And now you'll be the conduit to either refer them to their primary care provider and hopefully have a discussion with the primary care provider, letting them know what you prescribed and when you prescribed it. Another survey had 36% of dentists prescribed antibiotics in situations that are generally not recommended by the American Dental Association and report challenges to prescribing. And this is something that Dr. Palmier addresses. Those of you that work in healthcare facilities, including dental practices, are at greater risk for developing C. difficile if you ever need to take an antibiotic while you are working in a healthcare facility. Maybe it's for UTI or sinus infection. And anybody here who ever takes an antibiotic, you're all at risk. There's nobody at low risk for C. difficile infection. There are definitely people at greater risk. Again, clindamycin no longer recommended by the ADA for prophylaxis or initial infection. This is the boxed warning for clindamycin. And these are a couple of legal cases. These both were clindamycin prescriptions, but the second one was a concern. This was a 35-year-old father prescribed clindamycin for endo retreat and developed diarrhea, notified the dentist. The dentist prescribed an antidiarrheal because that is what they learned through a study club. And the patient died of toxic megacolon. The patient, the dentist found themselves in civil court, and was the patient's family was awarded in the millions of dollars because the jury decided that the study club did not align with the guidelines, right? So if you're prescribing outside the guidelines, what the study club tells you, if it's not aligning with the guidelines, and this is what your colleagues happen to be doing, and they believe they're getting good results, that may be a problem. All right. The recent study in UK suggested even a single dose of clindamycin can cause complications, including death and Clostridium difficile infection. Another showed that patients with community-associated infection had received care at an outpatient physician's office. And when they included dental offices and emergency department visits, that number went up to 83%. Nearly 1/3 of those had not taken an antibiotic. I have this document in your course folder. This is a comparison of different antibiotics and their risk for community-associated C. difficile. And you'll see, I may have mixed up the slides here. Clindamycin has an odds ratio, I think, of about 26. Doxycycline, I think it's 0.9. But you cannot use that document to say, well, I'm not really sure if this is a pulpitis or if the patient has an infection. So I'm just going to choose an antibiotic with a lower risk ratio, because It also has to do with the patient's constitutional situation. You know, are they immunocompromised? Are they over 65? Are they female? Are they visiting someone in the hospital? And you'll hear Dr. Palmier say, the number one thing we should tell our patients when we prescribe an antibiotic, stay away from a healthcare facility. Do not visit anybody in a nursing home, etc. So remember, my infection occurred 48 hours after returning to the dental practice for a 30-day checkup. Now, that's anecdotal. We'll never know. Did I come into contact with contamination in the dental practice while I was there? We won't know. How long can it take for patient-prescribed antibiotics become symptomatic? Up to 90 days, up to 3 months after the antibiotic. The American Dental Association does not recommend probiotics for trying to prevent C. difficile infection. And that is, they cite a study, Infectious Diseases Society of America. There is another study here that was recommended to me by someone who's an infectious diseases expert. However, they happen to be on the board of BioK, and this was supported by BioK. But showing that they believe that probiotics did have some effect, a positive effect. Now, I used to teach a course, well, I still do, teach a course on probiotics, and I took probiotics for a good portion of my adult life. Again, that's anecdotal. I don't anymore because I had a fecal transplant and I was told not to, because you can disrupt balance as well. All right, these are estimates for antibiotic-resistant related infections. Nearly half the cases in the US are antibiotic resistant now, and about 1/3 of the deaths are antibiotic resistance as a result of antibiotic resistance. Do you determine if your penallergic patient is truly penicillin allergic? Find out, because less than 1% of the population is truly allergic. And if we don't investigate, then we have to prescribe these other antibiotics, second and third tier, that put our patients at greater risk for C. difficile and other adverse events. There are links there to evidence-based guidelines. We have some questions about antibiotics. And as we close, I want to talk to you about infection control, because it's really, I believe, important to mitigate for these spores. Hospitals know this. We have Tara here. She will tell you if they have an outbreak, they're going to be breaking out the bleach or hypochlorous acid, depending on the hospital. Dr. Palmier no longer uses the wipes. Those are quaternary ammonium compounds. He no longer uses Cava wipes because they're ineffective. In fact, some studies show that Cava wipes or similar can cause more cross-contamination. So outpatient settings pose a significant risk. And this again is the antibiotics. Excuse me, the slide got switched here. And you'll find this document in your course folder, and you can receive that by tapping on the red banner at the top of the screen. So C. difficile, highly contagious, difficult to kill. About 95% of you that are using the microfiber wipes with quaternary ammonium compounds, be it Cava wipes, whatever, great products, kill what they're supposed to kill, do not kill spores. If you want something that's going to kill the spores, pick it off the EPA list K. This was a study that showed even the provider's work area was contaminated in healthcare settings with C. difficile spores. And that's the link to EPA list K. And this is a document also in your course folder on those quaternary ammonium compounds, a chemical class of emerging concern, because not only do they not kill the C. diff spores, they also are highly toxic. And the concern here is they're not well regulated either. Disinfectant wipes transferred C. diff spores from contaminated surfaces to uncontaminated surfaces. Another study that showed that hypochlorous acid versus quats, your quaternary ammonium compounds, more effective. Can C. diff spores be aerosolized? Yes. If somebody's using your toilet and they flush the toilet, they can aerosolize C. diff spores. Effective hand hygiene, absolutely important. And that course is available on demand right now on our website. Warning about bulk soap dispensers. If you're using these in your practice, get rid of them, because these nozzles are contaminated with fecal bacteria and others. You cannot clean them. You cannot disinfect them. you get biofilm growing in these. The same with the countertop pumps. So you should really go to a system that is touchless, like this, and that way your hands aren't going to touch the nozzle. You don't have to worry about the biofilm. So it's thought about 1 in 4 of these dispensers are contaminated. And there's some videos about that as well. So consider using hypochlorous acid and even electrostatic sprayer. And here's a link to a course that I teach on hypochlorous acid as well. Update your infection prevention protocol. What do we have for treatment right now? There are some medications now that have been FDA approved. So FMT, the fecal microbiome transplant, that requires admission into endoscopy, and it requires deep sedation, which carries a risk. Now this can be performed via enema in a medical practice, or in some cases at home. There are also capsules that can be taken that are live biotherapeutics as well. And those are the capsules, Faust. And then there's monoclonal antibodies and Plava, and then that requires admission to an infusion center. So closing remarks, we need education. We need to educate each other, let people know about this course. These are some very concerning conversations that I looked at online between patients that have no idea what to do. They need a dental procedure. They've had C. difficile in the past. This is someone who, 36, father of 2 small, beautiful girls. I'm sad, nervous, angry, and terrified that I brought this disease and the whole hell that it comes with it on my family. I got it from taking clindamycin for a tooth extraction, was in the hospital for a short time, and so forth and so on. And there's story after story about this. This is someone that had wisdom teeth removal, was given an antibiotic, developed symptoms of C. diff. Someone said, talk to your doctor. Have you had C. diff in the past? He said, yeah, I've had it 2 times this year. So nobody had asked him apparently if he had C. difficile. So you'll see these on there as well. Education, antibiotic stewardship. Make sure that you review and implement the ADA's evidence-based guidelines, infection prevention to mitigate further spores, advocate for C. difficile awareness and public health policy to improve the reporting requirements and vaccine development. I hope and pray every day that there will be a vaccine for this, because my options are very few, very few. If I get any infection in the future, I'm not sure if I'll survive it. We need to embrace technology and locally treat infection rather than grab or prescribe these broad spectrum antibiotics. Ask your patient if they've had C. difficile in the past. Here are the resources here, and more literature for you. I'm going to put the code up on the screen for you all and look at some of your questions. 795823 is the code. Question here: if a patient needs pre-med before treatment due to congenital heart issues, valve replacements, and they've had a history of C. difficile infection, do you not treat that day? No, you do not treat that day. Not at all. That patient may need to be hospitalized. They may need a monoclonal body infusion. They may need extra medication to help suppress the toxins in case C. difficile recurs. There is no way that that patient should be seen, at least without a conference with their medical providers and a treatment plan. Question from Alan: to properly kill spores, hypochlorous acid has to be used to wipe the surfaces after each patient, clean, wipe, dry. So what you do with hypochlorous acid, and the company that makes it is called EvaClean or EarthSafe, which I don't get any reimbursement for. And you use dry wipes and the spray. It's a cleaner disinfectant just for your high touch surfaces like the dental chair, the arms of the dental chair, maybe the counter surface that you're working on. The rest, you just spray it down with an electrostatic sprayer. It's a 4-minute contact time. Do probiotics help from contracting C. diff? You may have posted that prior to that slide. The ADA says there's not enough evidence, and probiotics are supplements. If you look at the complexity of the gut microbiome, there's a concern that we can actually disrupt some of these communities and subcommunities by causing a shift. And again, we're also asking patients to ingest bacteria. So some of your patients may not even be a candidate if they are immune suppressed. They can't, in some cases, take probiotics. The replacement for clindamycin depends on your patient. Any antibiotic can cause C. difficile. And patients that require the antibiotic can become infected with C. difficile, right? Antibiotics save lives. Our problem in dentistry, though, is that we are under pressure from the patient, from the specialist. Many of us are not prescribing according to the guidelines. And these patients aren't coming back to you by and large to tell you that they've had C. difficile. So you aren't seeing, I certainly didn't see the harm I was causing. I prescribed clindamycin in public health clinics. I had no idea. I don't know if I killed anybody or not. It's a scary thought. But that goes for any antibiotic. What's the replacement for clindamycin? I'm going to refer you back to the ADA's guidelines because it depends on the patient. Bleach kills C. difficile. Hypochlorous acid kills C. difficile. It has to be in the right concentration to do so. It has to be on EPA List K. You cannot leave here and go to Amazon and buy any old hypochlorous acid, even if it says it's hospital grade, because it may not be the correct concentration to kill those spores. And it may be too acidic. And if you're making hypochlorous acid on a countertop, that will not be a sufficient concentration. Hypochlorous acid is used in grocery stores. If you go into your produce section, you hear the mister, they're using a food-grade hypochlorous acid. Hypochlorous acid is produced by the body. Veterinarians use it for wound care. It's used on humans for wound care. It's used in mouth rinses. It's used to disinfect water and water lines. So it has a lot of applications. I can't say if something is a fair alternative to clindamycin. It depends. Is this for prophylaxis? Is it for, what's it for? And what about your patients? So azithromycin is not a candidate, or not all of your patients are a candidate for azithromycin, because azithromycin has other issues too. So take a look and review the ADA guidelines. And if you're not sure, again, shameless plug, take Dr. Palmier's course. He wrote the guidelines. He's one of the co-authors. So he's going to give you every case scenario. And he will talk to you about just the very few times you may want to consider using clindamycin, but by and large, not used. What if there's an infection present in regards to an infected tooth? So there is a link to odontogenic uses. That 2019 study, it gives you a decision-making tree. Is there swelling present? Is the patient febrile, and so forth? Just because they have an infection, and you heard Dr. Palmier talk about this, doesn't mean that antibiotics are required. Treatment is required. Treatment is required. So you'll hear him talk about that. Any other questions? All right, passcode 795823. If you're on a 10-day course of antibiotics, how long should you wait before returning for dental treatments or a post-op check? So for patients that are on a 10-day course of antibiotics, if they come to your practice and you're mitigating for spores, then you're doing everything you can. They shouldn't have to wait before their dental treatment, right? So like any other healthcare practice, we should be mitigating for the spores. But if you aren't and you're inviting them back into a contaminated environment, it could be 3 months and they could still develop an infection. So my recommendation is that we start applying the correct disinfectant. Do air filters help with spore reduction? Well, in the event that they might be aerosolized, but what helps is disinfectant and administrative controls. You don't invite a patient back in with an active C. difficile infection. And when I was infected, I called the practice to let them know I was in the hospital. The office manager called me back 3 days later. The periodontist never called me back. It was the office manager. She called me and said, look, doctor wants to know, are you going to keep your cleaning appointment Friday? I said, no. I just got out of the hospital with C. difficile. I will not be there for my cleaning. Well, we don't need to give you antibiotics. Not the point. The point is you don't want somebody in your practice with an active C. difficile infection, right? You wouldn't want me in your office. All right, 795-823. We're going to bring up a presentation here by our sponsor this evening, Dr. Jen. And they're going to talk to you about their own experience with a family member with C. difficile. I'm going to invite Peter here, Peter Eisenhuth, and tell you a little bit about Peter. Over the last 25 years, Peter has dedicated his career working in the dental care industry, helping doctors advance their level of oral care, working alongside his wife, Dr. Jennifer Eisenhuth, who's a board-certified orthodontist. Peter has spent the last 5 years researching and developing clean ingredient preventive oral care products using modern and advanced materials, in addition to his constant pursuit to improve and develop modern preventive oral care products. Peter works closely with dentists and hygienists throughout the country, providing instruction and education on the use of modern preventive oral care products. Welcome, Peter. Thank you for being here this evening. And I'm going to recommend that everybody go to the top of the screen here. We're going to put your banner here. And everyone, this is Peter, and he's going to talk to you about how they were impacted by C. difficile. And then we're going to give you an opportunity to be able to order some free samples and take a lunch and learn with Dr. Jen.
Thank you, Dr. Rolling. This is probably the third or fourth time I've watched your presentation. And every time I listen to it, it is gut-wrenching, literally, because our daughter went through this, of course. And so your story really hits home. For those of you that don't know who I am, yes, I'm Dr. Jen's husband. Dr. Jen was in the clinic all day, so I get to share our basically what we have to offer you as far as some free samples. We have a gut-friendly formulation, and I've never said that before, but I think it's appropriate. So before you guys leave, please click the link if you guys would like to receive some free samples of Dr. Jen's Nanohydroxyapatite toothpaste formulation. But in summary, my wife is a dentist, orthodontist as well. Our daughter, Claudia, though, is really the inspiration behind our brand. That's this picture says a lot. It's when Jennifer opened her clinic in 1996. But that little girl, Claudia, used to work in our clinic. She did everything from answering the phones to doing sterilization. But it sparked an interest and a passion for her to pursue dentistry. Unfortunately, after being accepted into dental school, her senior year at college, she was hospitalized with C. difficile. Claudia had a tooth infection from a fractured tooth. Because she was in a very remote college town, she was unable to see an endodontist right away. So the local dentist put her on antibiotics to help her get through finals week. All in, she was on antibiotics for 5 weeks in total, which basically, wiped out a lot of her gut bacteria, was exposed to C. diff spores, and hospitalized at the Mayo Clinic here in Minnesota. She was one of the youngest patients to be hospitalized with C. difficile, but I think that's an important note. C. difficile goes after all ages. And yes, if you get the right combination of antibiotics and if they're exposed to C. diff spores, it can happen to anyone. When we brought our daughter home from the hospital, the physicians gave us very clear directions on what we could do to help our daughter recover. Of course, she also had to endure the same treatment that Dr. KRoling did, the fecal transplant. It was quite an ordeal. It took her about 2 years to get her gut bacteria stabilized where she could attend dental school. She's currently a 4th-year dental student. But when we did bring her home from the hospital, we were given really clear directions on things that we needed to do as a family to reduce her exposure to chemicals that could further disrupt her gut bacteria. As a dentist, the first thing Jennifer looked at was our toothpaste. If you guys have not done this exercise, read the ingredients in your toothpaste. We swallow about 5 to 7% of what we brush with. If you have kiddos at home or in your practice, they're swallowing closer to 40%. So the ingredients that were in our toothpaste were ingredients like propylene glycol, sodium lauryl sulfate, synthetic flavoring, even fluoride our daughter couldn't use. And so what Jennifer did next was she did a deep dive into nanohydroxyapatite, realized it was gut friendly, didn't cause inflammation. When you swallow nanohydroxyapatite, it dissolves, delivering phosphate and calcium. However, Jennifer could not find a manufacturer in the US that was following the science. In fact, most of the products that are currently sold on Amazon today are private label formulations. The challenge with this is nanohydroxyapatite is very expensive. And what a lot of brands will do is they put in very low concentrations. They're generally not manufacturing their toothpaste. Why do they put low concentrations of nanohydroxyapatite in? Because nanohydroxyapatite is very expensive. The other option we're seeing out there is brands will substitute high quality nanocrystals for microcrystals, which are, their microcrystals are too large to actually penetrate the surface pores. If you'd like to learn more about the research and the science and the safety behind nanohydroxyapatite, we have a live lecture on the Dental Academy. There's also a recorded version. And then, yes, if you'd like to learn more about this for your office, we do lunch and learns. If you click the link on the top of the slide, not only will we send you free samples, but we'd be happy to buy your office lunch and get you an hour of CE on the science behind nanohydroxyapatite. But in summary, Jennifer has spent the last 6 years advancing oral care products with nanohydroxyapatite. She's considered one of the leading industry experts on nanohydroxyapatite. We do have fluoride-free options for those patients that do not want fluoride. In summary, for hydroxyapatite to be effective, we need high concentrations of 10%, but also nano-sized crystals to be able to penetrate the surface pores, but also occlude the dent and tubulos. What's even more powerful, if you do our lunch and learn, is you'll learn about the combining of nanohydroxyapatite with fluoride. 5,000 parts per million fluoride is a 1980s formulation. The dental industry has advanced across all spectrums, whether it's digital scanning, composites, implants. Within the oral care, preventative oral care products, formulations have evolved as well, mainly in Japan and Europe. What we have discovered, though, is if you can combine nanohydroxyapatite with over-the-counter levels of fluoride, you can actually give patients with, high caries patients more effective results, or higher levels of remineralizing. Dr. Jen did create a super paste through doing her research. It took her about 3 years to create this. It has 10% nanohydroxyapatite, fluoride at over-the-counter levels, and then xylitol. But this is really a product that we're getting a lot of feedback from dental professionals. It is disrupting the oral care industry. We tested this against 5,000 parts per million fluoride. You can see the results. It was 6 times more effective. We're hearing just some amazing stories throughout the country where patients that were on 5,000 parts per million fluoride, non-responsive, switching to our super paste, having just amazing outcomes. Here's an email that was sent to us recently. You can check out the bite wings, but these are the type of studies and case studies we go through during our lunch and learn. But I love these bite wings because a picture is worth 1,000 words. But in summary, this patient was a high caries patient on 5,000 parts per million, scheduled for restorative work. You take a close look at the February 2024 bite wings. She had lesions on 15 MO, 18 MO, and even she had radial decay in the dentin. She was actually scheduled for restorative work, but did not show up for her appointment. However, she did leave with Dr. Jen's super paste, returned 6 months later. The dentist decided to upgrade the bite wings to see how far the decay had advanced. And even he couldn't believe his eyes. I'll just read the email, part of the email that was sent. The hygienist sent this. She said, "I wish I had a video of the doctor doing the exam, looking at number 18 on the radiograph, checking in the patient's mouth, going back to the radiograph again, leaning back and pondering everything he knows about remineralization." And so, yes, our daughter became ill as a result. We had to make some changes in our household. We couldn't find a toothpaste following the science. And so Jennifer started creating her formulations. And, something always good comes out of something bad. And so we can really credit, our daughter for, the formulations that we've created. I hope that all of you that are still on, click the link so we can send you some samples of our fluoride-free toothpaste, but also our super paste. More recently, Jennifer just created a dry mouth gel that incorporates nanohydroxyapatite, vitamin K2, and D3. This is the first dry mouth gel of its type. You guys know this. Saliva has many roles. It's supposed to help with digestion. It's supposed to help with lubrication and moisturizing, but it also should be delivering a steady stream of phosphate and calcium in the oral microbiome or in the salivary pellicle to promote natural remineralizing. And so, yes, it's the first and only dry mouth gel incorporating the nanohydroxyapatite. We're getting some wonderful feedback with this product as well. Jennifer just received a call from a doctor who switched all of her patients from a very popular dry mouth gel to this dry mouth gel. After 2 days of using this product, this particular patient typically had to apply her dry mouth gel 3 times through the evening. She'd apply it before she went to sleep. She woke up in the middle of the night, burning mouth syndrome, and then woke up early morning hours with burning mouth syndrome. After 2 days of using this product, she was sleeping through the night. She called the dentist, though, because she had concerns with this product. Her concern is that when she woke up, she had too much saliva. It's a cute story. We cannot promise that this product will help patients with burning mouth syndrome accomplish too much saliva flow, but the science really supports itself as a premium solution for patients that have burning mouth syndrome and xerostomia. In summary, we have different formulations. We sell wholesale. We also have referral pads that you can tear off if you don't like to stock the toothpaste. As I said, though, we'd love for you guys to at least try our products. In summary, we are a dental family. This is Claudia, our 4th-year dental student on the left. That's our son, Gabriel. When our daughter fell ill, really the whole family rallied for our daughter. It also sparked an interest in a curiosity for dentistry in our son. He went on to obtain a master's degree in biomedical science. In fact, he's the only person in America who has a master's degree in biomedical science defending his thesis on nanohydroxyapatite as an anti-caries agent. Jennifer made our formulations for our family, her patients. She started selling her toothpaste about 3 years ago in her practice online. After about a year of selling her toothpaste, we started getting calls from dental professionals all over the country that were reading the science using our toothpaste, asking if they could buy our formulations wholesale for their families. And so that's why we're here. I'm just grateful to share our story. And thank you, Dr. Rolling, for not only sharing your story, but hopefully having a huge impact on offices to prevent patients from experiencing xerostomia.
Thank you so much, Peter, and to Dr. Jen and Claudia and Gabe and everybody. And I want to remind everybody that this presentation is also in your course folder, so you can take it back to your dental practices. And by tapping on that blue banner at the top of the screen, you can claim free samples. You can schedule a lunch and learn. And when you do so, you can also bookmark that URL to your device and take it back to your practices tomorrow to schedule it. And I see there's about 80 of you that have done so. So jump on. We had a couple of folks that have taken the lunch and learn with you, Peter. I don't know if you saw that and said it was excellent. So you've got a following on the Dental CE Academy now. So that's great.
Awesome.
Somebody'd like to know if we can share that discount slide again. So
yes, guys, if you do decide to place an order by going through this course, you get $100 off your first wholesale purchase. Write down DA100. If you're looking for samples for yourself, we have a code that's off 10. Either way, we would love to send your practice free samples. So if you click the link on the top, sign up for free samples, we'll get these to your office.
do you currently ship samples to Canada, and will you be at the spring ODA convention in May?
We are working on Canada. I expect us to resolve that. It says we're trying to figure out the shipping, so stay tuned. Yes, and then where's that conference, by the way? Is that in Canada or is that a local conference?
Is that Ontario, Lon?
I don't think we're not scheduled for anything in Canada right now this year, but
It's in Ontario.
yeah, the shows that we'll be at this year pretty much they are in the U.S. Thanks for asking.
Toronto.
Okay.
It would be great to go up to Toronto and Montreal. Okay. Any other questions? What ages do you and Dr. Jen recommend for these?
Yeah, that's a great question, Dr. Rolling. You've got to think about this. We have a lot of families now that are ditching fluoride because there's a study that came out showing a correlation or an inverse correlation between fluoride and IQ. We're not promoting that, but this is what parents are reading. So they're ditching fluoride. So what we would recommend for these families that do not want fluoride, especially if they have young kiddos, because these really young kiddos, if they're 2-3 years of age, they're going to swallow close to 40% of their toothpaste. So we have a fluoride-free 10% nanohydroxyapatite safe to swallow. Our fluoride super paste, it's the same as our mint super paste. It is approved per the FDA guidelines for ages 2 and up, but in Jennifer's practice, she doesn't like to recommend fluoride until the child is responsible enough to use a fluoride product. Her guidelines are if they're old enough to tie their shoes, they're old enough to use fluoride, but this is something that does require parental oversight. Unfortunately, we are seeing young children, though, at high caries rate because they're on products like Adderall or behavioral medications. Maybe they have underdeveloped archway, obesity, etc., that cause xerostomia. And if at the end of the day they have xerostomia, they're generally going to need more than over-the-counter levels of fluoride, and that's the benefit to our super paste. It's 1,000 parts per million fluoride, no prescription required, yet it has the 10% nanohydroxyapatite. But back to ages, we generally recommend 6 and up with our super paste, and the fluoride-free can be used at any age.
Excellent. And can somebody order just one tube, or are they looking at multiple?
Yeah, I guess if anybody is listening tonight and they want to try our toothpaste, they want to send it to their house, there's a code on the bottom of the slide. It's off 10. So we have a site for consumers, and you could share that with your patients as well. It's Dr. Jen Natural. That's where you would send patients to purchase our product. We do send out referral pads that you could do tear-offs. You give to your patients, they would get a discount. But regarding wholesale, that's the Dr. Jen Oral Care site. That gets you 40% off plus the $100 off your first wholesale order.
Great. And a reminder to everyone too, and they probably already got the email notification. Tomorrow night's the course on nanohydroxyapatite. So it's good timing. So you'll get to do a much deeper dive and hear from the Eisenhuth family, the creators here of Dr. Jen. And really, I think, and I don't say this lightly, you all are the global leaders of nanohydroxyapatite. You've well researched this. So anybody who's on here this evening, please make sure that you sign up for the class. Any other questions here for Peter?
I'll mention, if you watch the presentation tomorrow, you get Dr. Jen as well. So she's really the genius behind the brand. But yeah, I'd love to have you guys on tomorrow night if you want to learn more about the science behind nanohydroxyapatite.
Excellent. Well, Peter, thank you so much for being here this evening, and thank you to Dr. Jen for supporting this program that we have here, trying to get the word out about C. difficile and some changes that we need to make in our practices to improve our patient outcomes. And let me see here. If that, I think we could tell everybody good night. And thank you so much, Peter. Thank you again.
Thank you, guys. Good night.
Good night, everyone. Okay, I am going to remind you all one more time. If you didn't hear, if you tap on that blue banner at the top of the screen, you can order some free samples. You can also schedule a lunch and learn, and you will get CE credit for that lunch and learn because we manage that lunch and learn for them. So get your office signed up for lunch and learn and get more CE credit. And tomorrow night is the course on nanohydroxyapatite. Is there anybody that needs the code for this evening? One more time, 795823 is the code. And a reminder to all of you that March 28th, so a week from this upcoming Friday, we do have Dr. Thomas Palmier, the co-author of the American Dental Association's Guidelines for Antibiotic Prophylaxis and Odontogenic and Therapeutic Uses. It's a 4-hour training. And he shares his prescriptions, forms, his entire presentation. You'll also have access if you have questions after the course. And the course is also available to you on demand. So if you can't make it for 4 hours a week from Friday, you can access the recording right now and complete it on your own time. Any questions before we go? And does anybody need assistance with the quiz? 795823, and you can go to quiz on our website and tap on the navigation bar. You'll see quiz. Does anybody need assistance? All right, everyone. Well, I want to thank you for being here, and hopefully we'll see you again tomorrow night and on the antibiotics course as well. Good night, everyone.